unheard of, not unheard of, but I think something that's under-addressed. And they look at the overutilization of ER services amongst Medicaid patients and the uninsured. To give you an idea of how big the scale of this problem is, right now this is, the overutilization of ER services contributes to about $14 billion of waste, and Medicaid pays $7 billion of that. And I think an even more alarming and interesting way of looking at this is that 24%, or ER utilization, 24% of those patients are Medicaid patients, and that's only 18% of the US population, so there's kind of a fundamental disconnect there. So the next organization I'd like to introduce is called Moxe Health, and they came up with a great service called triage.me, and these guys are based out of Madison, Wisconsin, so I'd like to introduce Dan Wilson and Mark Olschesky.
Thank you very much. Hi, it's great to be with you guys today. To, I guess, introduce Triage.me for the first time. This will be the first demo ever given. Yeah, exactly. So my name's Dan, this is Mark. We used to work at Epic, kind of got our start in HIT that way, and have since left to create a platform catered to the underserved. So a little bit about what has brought us to where we're at today. About 50 days ago, actually exactly 50 days ago, we went to a hackathon in Milwaukee, Build Health, and we went kind of with the mindset that we were going to look for some engineers, some developers to work on another project we had going on. And while we were there, we wanted to work on something completely removed from what we were otherwise doing. And so as we were sitting listening to different community leaders talk about the health problems that they were dealing with, a woman, Mary, who worked with a system, Aurora, in the Milwaukee area, began talking about ED misuse. And really the prevalence within the underserved community who find themselves in the emergency department much more frequently for non-emergent or routine care. And so we wanted to take a look, and really the first reaction that Mark and I shared was, this is really not a technology problem. This is something that's very endemic with the system. It's a lack of access. It's embedded in human psyche and behavior, the cultural aspects. So let's definitely work on that one. And so, here we are, 50 days later, ready to launch. This product is in the gestational phase of something between like a kangaroo and a fox. So we'll see what we come up with here. But as we were talking with Mary and digging in a little bit more as to what were the root causes of ED misuse, we identified kind of three primary tenets. One being an awareness or lack of knowledge within the community as to what resources existed. There was a financial component. So the ED appears to be free, whereas going to a clinic, you have some small copay or a sliding scale payment. And then lastly, there's really underpinning everything, a very real lack of access within the community. And so the solution we came up with looks to address all three of those. And before we jump into that though, I want to get you guys involved a little bit. And as we were looking at this community, I think there's a lot of great solutions geared for smartphones. We wanted to create something for this population, so everything is SMS based. And here we were kind of envisioning a much wider group of people, and we wanted to split out the load. I think it doesn't matter what number you text. We also have internationalized everything, so within this population, in general, 30+% are best served by a language other than English, and we wanted to make sure that whatever solution we came up with had them in mind. So with that, I'd like to turn it over to Mark.
Thank you. And make sure before the end of the session, everyone put your cell phones away or the teacher will take them after class. You'll have to stay for 15 minutes after that. So what we're going to demo now is Triage.me, and we're going to show it to you right here. So when we come to the front page of Triage.me, you can see the design has a warm feeling to it and is a bit whimsical. The reason and our guiding principle behind this is that we know that the people who are coming to our site and dealing with Triage.me have two main attributes. First, that they're sick, hurt, tired. And the second thing is we know that they want help and they don't know where to get it. And for those people, that's scary. So we try and make Triage.me as comforting as possible. Our logo is this bee, which is because at the hackathon we were at in Milwaukee, we were actually sharing space with a beekeeping convention. And he's kind of become our little mascot. So I'm going to tell you a story of a person named Rosa. Rosa's at work, and she thinks that she might be pregnant and she needs a pregnancy test. So what Rosa is going to do is, based upon her last ED visit at discharge, she received a paper or a text message or something that told her that use Triage Me the next time to find more appropriate care. She clicks the Start Triage button, and she comes to a simple form with information to fill out concerning her demographics. So she enters a cell phone number, an address. We ask her the standard AHRQ questionnaire to ascertain that Rosa, in fact, does not have a high acuity and should go to the ED. In this case, for a pregnancy test, she doesn't have an emergent situation, so she'll click no. We ask her a free text question of what she can enter here. And we ask in a simply worded way, does the person coming to the clinic have insurance? Or we ask if they would have Medicaid, some other local type of insurance, or if they're a self-pay patient. At this point in time, Rosa clicks on the Fly into Clinic button. And in the back end, if the patient was on Medicaid, we'd be routing them to the nearest FQHC. We're routing proximity. We're also taking into account how busy the clinic is. So we route Rosa to the nearest community clinic that's open and is available for care. In this case, we're telling Rosa to go to Unity DC General. We have the address, we have the phone number. Rosa can also see the clinic availability between 1 and 2 hours of a wait, which, comparison to the ED or some other clinics, not too bad. At this point in time, we also have an incentive here where Rosa might receive 10% off of a prescription if she checks in at this clinic, providing the financial incentive to do the thing that's best for the system, for hospitals, for Medicaid, et cetera, and helps Rosa out a little bit too. At this point in time, Rosa's decided that she's going to go to the clinic. This seems like a good proposition to her, so she's going to click yes here. At this point in time, to improve the facilitation of access, we provide Rosa with a multitude of ways that she can get to the clinic, particularly public transit directions. So here at this point in time, as Rosa, I can see that I would take the B2 bus. It would take me 17 minutes to get to the clinic, which isn't too bad. So now I'm going to put on another hat, and I'm going to imagine that I'm a staff member at the clinic. What happens now that we have this text and this information from Rosa? So I'm going to go back to the page. I'm going to click on the client login page from here. Back from our old EMR days, we remember how important HIPAA, privacy for patients, and all this other type of thing is. So we made sure that we build a secure platform so that patient data remains uncompromised. So I'm going to log in here. So the biggest problem that we realized whenever we were creating Triage Me is that the clinics that the people that we're serving are going to don't operate like many clinics that you might be familiar with. From 8 to 5, Monday through Friday aren't typical hours. A lot of clinics are mobile, don't have a set address. They're only open 1 or 2 days a week per month, have erratic wait times from no wait time whenever a lot of patients no-show to having a super crowded waiting room whenever patients all of a sudden are showing up for walk-in appointments. So what we've created is a suite of tools that allow patients or allow clinics to communicate within a community their status of whether they're open now and their clinic status to let patients and other clinics know if they're willing to accept other patients. So what I'm going to do is I'm going to click on the Manage My Clinic button. And I can see some information here about a clinic name that I might be updating. I can update the address here if I wanted to say that we are in a new location. So let's say we're at 14th and U Street. Whether we're currently open and our wait status for the day. And by saving this, I publish it so that the other clinics and patients know that we're ready to receive patients and can be routed to it by Triage Me. Now on the back end for clinic staff, from the text messages that we've been receiving, we also now have populated a list of incoming patients based upon information that we have. For example, we can see some of the text messages that we've received here at the Unity Clinics in Whitman Walker, which is one of their partners, where we now have the patient's phone number, which we've stripped out, chief complaint, the last time stamp that we've received from a patient, the clinic they were sent to, and their insurance and type. Based upon this, we already have automated information and that we know the patient's going to arrive, so we can check them in upon their arrival. But we also have their phone number based upon their chief complaint that we could call this person and get in touch with them if you had a call center or any other type of advanced staff. So we've come up with a set of tools specifically for this population. We're excited how we can engage people with it. And now Dan's going to talk a bit more about how we can use that data.
Yep. And one note on this, because we're most excited about the SMS-based platform that we've created. So we have the web front end so you can visualize a little bit better what the system does. But for those mobile clinics, for the nurse who may be on the street, all of that information can be updated by text. So they can update what street corner they're on, and patients can be routed appropriately at the moment that they show up on that street corner. So we are at a data conference, and I think Mark has touched on how we are looking to address some of the financial misincentives through the discounts and through the other kind of coupons or rewards, how we want to address the access or the knowledge by making a very prescriptive-based system. But really the underlying cause of many of the problems facing this community is a lack of access, a very real access. And so that's where the data that we're generating comes in. Talking with clinics today that serve this community or with organizations, you know what zip codes are underserved. You know where the patients are living. What you don't know is you don't know where in the community they're at when they decide they need to try and find care. So Rosa was at work, somebody may be picking up their child at school. It's at that moment they determine they need to go in. They may not know what the closest clinic is. So the data that we're generating is a series of kind of geocoded lat longs of where the patient starts, where do they end, what type of insurance do they have, what was their complaint, and we can use this data to help organizations make more informed decisions on how you allocate your resources throughout the community. And the vision that we have, the goal that we want to work towards is justification of increasing true access in the community. If we can say that there is a region that a clinic closed at 5, but had you stayed open till 7, there were 30 Medicaid patients you could have captured. You get your encounter rate up and you improve overall access in the community. And it's really that vision of opening things up that we are driven by. And I think as we begin to add services to this platform, we want to continue to keep it incredibly streamlined and simple for the patient. It's that way by design. We want to offload everything onto the back, but continue to collect more significant data that we can use to help organizations make more informed decisions.
Yep. So that's what we have today. We're 50 days in and we're pretty excited about it, and hopefully we've shown you a few things that you like so far today. It's been a bit of a sprint over the last 50 days, so tomorrow I think we're going to take the day off, and then on Friday we're going to get right back to it. We've received a lot of great feedback here at the conference so far, and we're interested in your ideas. We're interested in thoughts and ways that you can engage a specific patient population with tools that meet their needs. So we're going to be in booth 43. Feel free to stop by afterwards and chat with us. We love talking. And otherwise, we have another 3 minutes and 17 seconds for questions.
So guys, so very, very impressive first cut. Has this gone out to a human being yet, or is it still just you just shown them it's the new?
So it launched live yesterday morning when the booths opened.
That's a great place to be. So don't take that as a criticism. That's great.
No.
Have you guys looked at other models in this area and looked at what both on the sort of commercial side ZocDoc is doing, but also My Health Direct? Are you familiar with those guys?
Yes. So actually, Aurora, the organization that kind of influenced this, is using My Health Direct. So we've been talking with them about how this fits in, and I think, My Health Direct offers a lot of great services, but what we like to do is say, what is the absolute perfect state? And the perfect state is that the patient's never showing up in the ED to begin with. Right. And so that's a model that relies on pulling the patient in. And I think that the real solution, or the solution we like to create, is something that says, let's get you to more appropriate care before you ever arrive, and let's address some of the behavior, cultural, education type issues proactively. And so that's how I'd say we're different from a My Health Direct. From a ZocDoc, I think they're doing a lot of really great things, and we're looking at a very different population, I think. And so whereas if we were to make this a smartphone application, you open up a lot of opportunities that are very cool, but not as relevant to the group that we're working with. So I think that that's kind of the distinction we have with a ZocDoc.
And then one follow-up, go back to your previous employers who now have a massive footprint across the US, as you guys know too well. What do you think, have you talked to them at all about the likelihood of integrating this back in with them or other? How is this going to fit? I mean, a lot of those little clinics wouldn't have an Epic system, but I mean, can you get a sense of how that might impact?
So I think the way that it would work specifically is that we have an API in which we would load our clinic information into EMRs. So I don't know if we'll receive as much information out of the EMR, but we have a lightweight framework where we can essentially have wait times for clinic and that clinic dashboard that we saw that we can put pretty much everywhere. We want to share that. That data doesn't belong to us, it belongs to the communities that we're working in. So I think proactively, the interoperability there relies on our ability to have data in a website for a community in an EMR, putting it in the places where the people who use it can access it easily so they don't have to be toggling between multiple systems.
Another 47 seconds if there were any other questions. I'm sorry? Okay, yes.
Yeah.
Thank you very much.
Thank you.
That's cool stuff, guys.